Hello again. So now I'm just going to give you a little bit of the clinical issues that may arise when treating individuals with borderline personality disorder. There are a lot of things that a clinician needs to be aware of and know due to the nature of borderline personality disorder. Among the issues to be aware of include the fleeting nature of the borderline personality disorder client's feelings towards the clinician, the rate of suicide among sufferers of BPD, the clinician's own attitudes towards clients with BPD, attachment issues that may arise with BPD clients, awareness that they often engage in high conflict litigation, and the importance of consultation. So clients with BPD often have fleeting views and feelings towards the clinicians that they work with. So they often have distrustful or split relationships with the clinicians that treat them. In other words, oftentimes BPD clients may idealize their clinician one moment or day and then devalue them another. It's like what I was talking about in my introduction with the criteria of borderline personality disorder. And so an example of that would be on good days, they may idealize their clinician by making statements such as, "You're wonderful, you've helped me so much, and you've gotten my treatment right from the start, you're just the best." However, on their bad days, they may devalue their clinician by making statements such as, "You're the worst, you don't know what you're doing, or working with you is a waste of my time." So it must be noted that a BPD client's idealization of a clinician may stem from the validation that the clinician offers the client and or the promise of relief from certain symptoms of BPD. So the protective message that these can send the BPD client can result in more trust in the clinician, but can also foster dependency, emotional dependency. And additionally, when an expectation of a BPD client is not met, then the clinician may be set up to be devalued. So the clinician may be doing everything right for the most part, but if the client doesn't feel that they are, or they feel that they've been treated unfair for whatever reason, it kind of sets the clinician up to be devalued. Is pretty much all that is saying. So for this reason, it's extremely important for a clinician to keep their goals and expectations realistically, to inform the client that there will be ups and downs throughout the treatment process, and reassure the client that together the ups and downs will be worked through. So by pretty much making the client aware of these things, the clinician will at least possibly reduce the chances of the client devaluing them. So, furthermore, it is important to remember to not react to the intense emotions that the BPD client may exhibit during a period of devaluation of the clinician, but instead, responses should be modest and conversational. So if a client comes at you and is devaluing you and saying that you can't do anything right, they hate you, you're the worst, reacting to them in the same way they are reacting to you is not the way to go. You want to handle it appropriately, and the appropriate way to do it would be modest and conversational. Just take it as it is. Don't take it personally. Also, another issue is that individuals with BPD often engage in self-injurious behaviors, including suicide attempts, and other self-harming behaviors. So, in fact, self-harm so strongly characterizes BPD that when individuals present with recurrent self-destructive behaviors, the diagnosis of BPD automatically comes to mind. It's also estimated, as I said in my introduction, that about 9%, well, it's 8 to 10, but so median, 9% of BPD individuals actually complete suicide, which accounts for 9 to 33% of all suicides. Although some individuals with BPD engage in suicide or suicide attempts, other self-harming behaviors that often present with BPD include cutting, burning, hitting, headbanging, hair pulling, and other harmful acts. Pretty much anything that they can do to harm themselves. It's important for a clinician to be aware of the likelihood of a BPD client's participation in self-injurious behaviors so as to best treat their client and help the client reduce the urge to self-harm. Additionally, it's important for clinicians to differentiate threats or acts that communicate a cry for help from those that have other motivations. In other words, it's important to know the difference between cries for help and a true desire of a BPD individual to end their life, so as to know what interventions need to be put in place. It's also important for the clinician to understand what things may trigger the self-harm or suicidal ideation. If the clinician is aware of the client's triggers, they can work to either reduce the triggers or work on teaching the client skills for being able to better cope with those triggers. So just as an example, many borderline personality disorder individuals will engage in self-destructive behaviors when they feel rejected or abandoned, when their expectations are not met by another person, their frustration about being treated unfairly arises, or they feel that they should be rejected because they're a bad person or have done a bad thing. And so the next issue is that it's important for a clinician to be aware of their own attitudes towards the individuals with BPD. BPD carries such a stigma with it that it often results in pessimism on the therapist's part and others, really. So a lot of times when a BPD client comes in, a therapist may already, take the client on, but they may not have high hopes for that client. And as I got from one of my resources, therapeutic pessimism refers to an inclination for professionals to anticipate a negative outcome or the perception that the service user recovery is unlikely and treatment will be deemed ineffective. So that's pretty much just going back to what I just said about clinicians automatically thinking or jumping to, oh, this person is not going to be treated, they're not going to be helped. So due to the nature of BPD, especially the significant instability, many clinicians enter into a therapeutic alliance with the BPD client with a negative attitude and little hope for change, which in turn influences the therapeutic alliance as well as the therapeutic process as a whole. Many clinicians may become frustrated with the client because they do not comply with the treatment, and there's incongruence in the treatment expectations of the client and the clinician. So if the client thinks that it should be done one way, but the clinician thinks another, it can cause a lot of problems. As a result of this, clinicians may feel powerless and subsequently non-therapeutic behaviors on the part of the clinician, such as irritation, anger, or even aggression can arise. So, in such situations that the patient or the client is irritated with the clinician, then the clinician may respond to that with anger or irritation or frustration that the client picks up on that can cause problems as well. So it's also crucial for the clinician to be aware of their own attitudes toward the client and work to develop their own self-awareness and informed knowledge in order to best work with the client and avoid this therapeutic pessimism. And so another issue that can arise when working with BPD clients is attachment issues. They may become a concern, so it's important for a clinician to set boundaries, be wary of becoming too attached to the client, and be careful about the client becoming too attached to the clinician. So when a clinician enters into a therapeutic alliance with the BPD client, the client may feel that they have found someone who can fill a void that they have had all their life and may become attached. It's kind of like I noted earlier about the clinician's validating responses and support can cause the client to really idealize the clinician, and also it can cause them to become attached to the clinician. However, when, as I already noted, when the client sets unrealistic expectations of the clinician, then they may demand services, feel rejected, feel abandoned, and devalue the clinician as a result of that, which again can all hinder the therapeutic process. Another issue that a clinician must be aware of when working with BPD clients is that they are the most likely to engage in high conflict litigation. When a BPD client feels rejected, abandoned, or that they've been treated unfairly, they may seek revenge upon the clinician in the form of a lawsuit. Being aware of this can help the clinician take necessary steps to reduce the likelihood of this occurring. Although you may take all the steps necessary and you may still not be able to avoid it, but by being aware of this, you can take measures that can at least try to reduce the chances of that happening. So additionally, it's also vital for a clinician to understand the importance of consultation to ensure that they're providing the best care for the BPD client and to reduce the possibility of litigation. So if you're a clinician working with a BPD client, it would be helpful to consult with others because they can help you take steps necessary as well, or they can give you advice on how you should handle the situation with the BPD client, and that makes it that reduces the chances of them pursuing a lawsuit against you. So pretty much all that I have addressed so far are the main issues. There are tons of issues that you could talk about, but those are the main and core issues that a clinician has to keep in mind and has to be aware of when working with BPD clients. And also, I just added in I have a couple of following tips for dealing with a BPD client. Not necessarily issues, but just extra things that a clinician can be aware of and can implement when working with a client, just to make it a little bit easier and make the process go a little bit smoother. So I'm just going to list them off, and that would be: limit the number of staff that interact with the client. Negative or hostile attitudes towards BPD clients should be avoided. Demands of services should not be honored. And that's not to say that if the client comes to you and asks for a certain thing that you just shouldn't give it to them, but if they are demanding services that aren't really necessary and it's in the nature of a BPD individual and it's inappropriate, you shouldn't give in to that. Inform the BPD client of the possibility of ups and downs in the treatment, so as they can set realistic expectations, at least to some extent. Listen respectfully, even to outbursts, without being defensive. That goes back to what I was talking about earlier. You know, your client may come at you devaluing you and saying horrible things, but you just want to listen respectfully, and don't get defensive, because like I said earlier, don't take it personally. Don't react to intense emotions, which we already talked about. Work with the client on misperceptions rather than criticizing them. Be supportive, but do not get too attached. Do not ignore or be abrupt with the client. Set clear boundaries and maintain them. If you set boundaries and limits, but you always cross them, the BPD individual will pick up on this, and then they'll continue to do that. Don't get pulled into the high conflict world of the client. Again, set limits on how and when you communicate. As I'll talk about actually in my paper, DBT usually wants the clinician's contact information to be available just in case the BPD individual needs it, but it's really important to set limitations on that, on the communication, just because if you don't, you may be getting phone calls all the time, and again, that's part of maintaining those boundaries. And then also avoid bending boundaries or limits to reduce the emotional intensity of the client. So if the client is trying to cross one of those limits or boundaries and they get really upset about it and very emotional and have an outburst, don't give in. I know it may be appealing to try to settle them down, but don't give in. Also, give the client full attention, maintain eye contact, be empathetic, and simply try to understand the client in their point of view. And that pretty much sums up the issues that a clinician may encounter when working with a BPD individual, and just some tips for dealing with them.